All right, let's dive into a really intense medical condition. We're talking about a situation where one of your own organs literally wages war on itself. It's called acute pancreatitis, and it's a truly frightening process of self-destruction. So just imagine for a second, what would happen if a vital organ, an organ that's designed to break down your food, suddenly flipped a switch and turned those powerful digestive chemicals inward? Well, this isn't some sci-fi plot. It's exactly what goes down in acute pancreatitis. So what is it exactly? At its heart, acute pancreatitis is a super intense inflammation of the pancreas. And the key term here, the one you really need to remember, is autodigestion. That's when the enzymes that are supposed to be digesting your food get activated way too early and start, well, digesting the pancreas itself. It's a painful, destructive internal process. Now, this kind of internal chaos doesn't just happen out of the blue. Something has to trigger it. So what are the culprits? What could possibly light the fuse for such a dangerous condition? Let's take a look at the usual suspects. In the medical world, we love a good mnemonic to remember things, and for this, we use I get smashed. And as you can see, the list is pretty wild. It's got common stuff like gallstones and ethanol, that's alcohol, but it also covers everything from infections like mumps to autoimmune problems, physical trauma, and yeah, even something as out there as a scorpion sting. But here's the thing. Even with that huge, long list, the vast majority of cases really just boil down to two main triggers. Gallstones are, by far, the #1 cause, usually by blocking a really important duct. And, coming in at a close second, is heavy use of ethanol, or alcohol. Okay, so we know what triggers it, but how does a gallstone or too much alcohol actually make the pancreas attack itself? Well, it all comes down to this disastrous chain reaction that kicks off deep inside the pancreatic cells. It all starts with some kind of injury or a blockage. This causes a really important enzyme called trypsin to activate prematurely while it's still inside the pancreas. And once trypsin is switched on, it's like the first domino in a huge line. It just sets off all the other digestive enzymes, unleashing this massive chemical assault that leads straight to autodigestion and inflammation. I love this analogy. Think of your pancreas as a super high-tech kitchen, and its enzymes are the cleaning robots. In pancreatitis, those robots get the signal to start cleaning while they're still in the storage closet. So what do? They start dismantling the closet and then the kitchen itself. That, right there, is the essence of this disease. So with all this chaos happening on the inside, how does the body sound the alarm on the outside? Let's talk about the key warning signs, the symptoms that scream, something is seriously wrong here. The absolute classic sign is this severe, deep pain in the upper belly that often feels like it's boring a hole straight through to the back. And here's a huge clue for the doctors. Patients often say the only thing that gives them even a little bit of relief is leaning forward. Of course, this usually comes with intense nausea, vomiting, and signs of system-wide distress like a fever and a racing heart. Now, in the really, really severe cases, two very specific and pretty alarming signs can show up. There's Cullen's sign, which is bruising that appears around the belly button. And then there's Gray-Turner's sign, which is bruising along the flanks, the sides of the abdomen. And let's be clear, these aren't just simple bruises. They are signs of internal bleeding from that inflamed pancreas. Seeing these means the situation is critical. Okay, so with symptoms like these, a doctor is definitely going to have a strong suspicion. But to be sure to actually confirm the diagnosis, they rely on a really clear, systematic checklist. The diagnosis gets locked in using what we call the 2 of 3 rule. Simple, right? You just need to have at least 2 of these 3 things. First, that classic abdominal pain we talked about. Second, blood tests that show your pancreatic enzyme levels, specifically lipase or amylase, are at least 3 times higher than normal. And third, you need some kind of imaging, like a CT scan or an ultrasound that shows clear visual evidence of pancreatitis. And while doctors check for both amylase and lipase in the blood, lipase is really the star player here. It's considered way more specific to the pancreas, which makes it an incredibly reliable marker for pancreatic injury. Once that diagnosis is confirmed, doctors will often use scoring systems to figure out just how severe the attack is and what the patient's prognosis might be. So once the diagnosis is made, it's all hands on deck. Managing this condition is absolutely critical because severe cases can spiral into some devastating complications. We're talking tissue death, shock, and even multi-organ failure. So how do medical teams counter the attack? The initial treatment is all about supportive care.
The very first step is to give the pancreas a total break, which means NPO, or nothing by mouth, not even a sip of water. The second, and maybe the most important step, is aggressive IV fluids to keep blood pressure up and protect the organs. Then, of course, strong pain relief is a must, as is oxygen support if the patient needs it. The entire goal is to support the body so it has the resources to start healing itself.
But wait a minute, that brings up a pretty logical question, right? If a patient can't eat or drink, maybe for days, how on earth do they get the nutrition they need to fight off this incredibly intense illness? Well, the answer to that has actually changed a lot over the years. We used to rely on giving nutrition straight into the veins, but now we know it's much, much better to use the gut if we can. So early enteral feeding, that's using a tube to send nutrients right into the intestines, is the way to go. It helps maintain gut health, and we've seen it leads to way better outcomes. Once the patient is stabilized and the immediate crisis is over, the focus shifts to tackling the original trigger. Why? To make sure this never happens again. If a gallstone was the culprit, a procedure is done to remove it. If it was alcohol, complete and total abstinence is absolutely non-negotiable. And for other causes, like super high triglycerides, there are specific treatments aimed right at the root of the problem. And this is a super important point, a common misconception. It's easy to think that with an illness this severe, you'd immediately start pumping the patient full of antibiotics. But that's usually the wrong move. Acute pancreatitis, at least at first, is a battle of inflammation, not infection. Antibiotics are only used if there's solid proof that the damaged pancreatic tissue has actually become infected. So the big takeaway here is this. The immediate battle is all about fighting inflammation with aggressive, supportive care. But winning the battle just brings up a much bigger question, doesn't it? Once the fire is out and the patient has recovered, what fundamental long-term changes are needed to make sure this devastating internal war never, ever starts again?